Good afternoon, Abdullah. I'm Sheikh Ibrahim, a nurse from the University of London. I will be taking you through head-to-toe assessment this afternoon. I hope you are ready to comply with me. Okay, I just need to confirm your name quickly. Are you Amadou Kabo?
Yes, sir.
Okay, Amadou Kabo, okay. And I can say you were born on the 7 March 1998. Can you confirm that?
Yes, sir.
Okay, that's good. Okay, let me just see if the bed is well firm. Okay, the bed is firm. I can see you look good today. Well structured, well positioned. Wow, that's good of you. So I'll come back. Give me just 1 minute to bring my equipment.
Okay, move forward.
Oh, Mr. Amado, I'm back, and we are showing this my trolley. I use this as my trolley, then I put my instrument there. Oh, Mr. Amado, I'm back, and please, to maintain patient privacy, I think I have to take you guys out. Please, excuse me, relative, and I screw my bed. So to start my procedure, I quickly go to hand. Okay, I start by assessing the entire body for temperature, mercury. Can I just please excuse me? Okay. Okay, so you can see your body will be moist. The temperature will be within normal. So that's a very good one. So, Mr. Amado, throughout this procedure, I will be changing your position. So, but that will not make you discomfort. Yeah. In case you feel discomfort, please report that to me. And for your privacy, you will be putting on the patient's gown. Can you place it quickly and wear the patient gown? Okay. Okay. So, okay. Okay. You can go back to bed. I will start by assessing the head. For symmetricity, I inspect. The head is symmetrical, and looking at the forehead, symmetrical. Looking at the face, you can see symmetricity. The nose is at the mid of the face, and I palpate slightly to feel for any tenderness. Is there any lesion in the head? Nothing like that. I look at the ear. Is it evenly distributed? The texture, is it the actual texture? The color, the ear. Okay. I look at the face for symmetricity. Looking at the eye round, it is symmetrical. Coming to the pupillary foci, you can see that they are aligned very symmetrical. Coming towards the nostrolabial folds, very symmetrical. Looking at the mouth, the contour of the mouth, very symmetrical. Palpate at the back of the ear to feel for the mastoid process if there is any inflammation, nothing like that. I continue with the inspections or the assessment with the ear. I assess the ear on both sides, check for color, is there any swelling, size, I look for size, color, any swelling. Is there any tenderness? I palpate for tenderness or pain. Is this symmetrical to this? Yes, you can see that the both ears are in the same position. Okay, that's a very good one. Then I inspect into the standard ear for any wax, any sealing, any drainage. I palpate around, I palpate the trigos, the auricle. If you feel any pain, please report that. As I palpate, any pain you feel, please report that. Okay, nothing like that. Then I want to assess for the conduction of the ear. I want to do the whisper test and to confirm if the vestibulocochlear nerve is working. That is the clear nerve. 8. So, Mr. Amado, please, can you just give me your back? Thank you. Okay. So in this assessment, I will cover one part of the ear wherein I speak into the other ear and expect the patient to verbalize any number or anything I'm calling. So please, Mr. Amado, I want you to repeat the same thing you are hearing from me. Is that okay?
Okay.
2,
2,
4,
4,
C,
6,
C,
C,
D,
D,
7.
7.
Okay, I cover this other ear, whisper into this, B,
B,
C,
C,
5,
5,
1. Okay. The patient was able to verbalize all the number and letters I call, which shows that the reciprocal nerve is working and there is conduction of air. Coming further, I come to the face again. Can you just turn this way? Come into the face. Okay. I want to continue by inspecting the eyes. Is there any swelling around the eyes? No, I cannot see that. I palpate a little bit around to feel for any pain. Please, if you feel pain, please let me know, yeah? Tell me if there's any pain. No pain, I palpate. I pinch down slowly to look at the conjunctiva, pink, looking at the eye. Open the eyes, please. Okay, it's white. I can see that the pupils are at the center of the eye, and the pupils is round. Okay, so I want to check for reaction of light. The pupils. In this case, I will use my pen light. I want to see how the pupils can dilate and how it can constrict towards light. I point. I either point at the side or I can point and take the light towards pupils. I can see it constricts when the light goes closer, and as it comes farther, it dilates. That is checking for accommodation. So during this process, just after you have done, you verbalize, you are finding that using a very short acronym, which is PRIRA, we call it the pupils can't. The pupils is equal, round, and react to light and accommodate. That is PARRNA. The pupils is equal, round, react to light, and accommodate. So that is the finding. And I want to continue by assessing the eye. I'm going towards finding out the peripheral visual fields. And in assessing the peripheral visual fields, I'm assessing one clear nerve as well. That is to know the sharpness of the eye. Although I'm assessing, comparing the patient's visual field to mine, assuming my own is normal. So I will tell my patient to just cover one of the eyes. Cover one of the eyes with your hand. Ensure you don't see with that eye. So after that, I have to cover the same opposite eye. Then I will tell the patient to call for me the number of fingers in any position. So I will be given using 4 quadrants, in 4 different positions, different hands, and I expect the patient to verbalize the number of hands. So, Mr. Amado, how many hands can you see? Fingers?
2,
How many fingers here?
1, 2, 1.
Okay, I repeat this for the other eye. Close the other eye. Go.
1, 2, 1, 2.
Okay. That shows that the patient's visual field is normal. And you can also say that the acuity of the eye is normal, and the cranial nerve too, the optic nerve is also working. And I will be also assessing the 6 cardinal points, which we also the 6 cardinal points of gaze, which some people call the 6 ocular movements of the eye. So during this assessment, I will be also assessing 3 cranial nerves simultaneously. and one is 3.5, 3, and we have 3.5, 2. Okay, I'm not right. We have 3.5, 2, and 3.5, 6. So these are the 3 3.5 we'll be accessing simultaneously, together with the assessment of the movement of the eyes, the muscles of the eyes. So please, Mr. Amado, you have to remain your head in fixed position, ensure it does not move, and let the eyes move in the direction of this pen. I hope you understood that. Okay. The head should not move. Okay, that's a very good one. That shows that the 6 muscles of the eye are active, they are working, and the 3 nerve spurs are also working. That is the 3.5, 3, which we call the oculomotor nerve, the 3.5, 4, the tracheal nerve, and the cranial nerve, 6, which is the abducens nerve. So I will be checking for reflection of the light in the pupils, and I will flash my pen light again into the eyes and look into the pupils if there is equal reflection of light at the center of the pupils. Okay, I can see that reflections of light in the pupils is at the center. That's a very good one. So to continue this, I will be going to access the nose. And accessing the nose, I observe, I inspect, I look at the color of the nose, if it is uniform to the color at the face and on the face, and I will also assess the shape of the nose. The shape of the nose. Okay, the patient is feeling a little bit discomfort of the coat. Okay, I observe the symmetricity of the nose. Is the nose at the center of the face? Yes, I look at the patency of the nose. Can I just see quickly? Okay, you can see that the nose is open on equally, and the nasal septum is at the center. Okay, I palpate around the nasal bone for any pain, any tenderness. If you feel any pain, please let me know. Also, are you feeling any pain? Okay, that's a very good one. Then I access into the nose tree. I inspect there if there is any mucus or is there any blockage of the nose, but I can see there's no blockage. So I'll be coming to access for the olfactory nerve. That is the clear nerve 1. That is the nerve for smell. So I will use my alcohol hand sanitizer and allow the patient to tell me the type of smell, and he gets, so I will close one part of the nose. Are you smelling anything?
Yes, sir.
Okay. Are you smelling anything?
Yes, sir.
How does it smell?
It's like alcohol.
Okay, so you see, you ask your patient if how the smell is, and that shows that the olfactory nerve, 3.5 is also sensitively working. Then I continue my assessment to the mouth. I inspect the mouth, looking at the color, looking at the texture of the lip. Yes, is there any cracks? Is there any break on the lip? Nothing like that. Then, if you look at the contour of the mouth, you can see it is well aligned. I go into the mouth using my tongue pressure. I let the patient open the mouth. Mr. Amado, please. I want you to open the mouth. I want to inspect around the buccal mucosa. I inspect if there are any white patches, nothing like that. Observe the teeth. Is there any dental caries? Looking at the gingiva Can I just look at the gingiva? Is there any inflammation, anything like gingivitis? No. Looking at the floor, open the mouth. I look at the back of the mouth, that is the pharynx. Bring the tongue forward. No, bring the tongue forward a little bit. Depress tongue. I look deeper. I can see the uvula. It is not inflamed. Looking at the tongue, see it is not inflamed as well. So can you just take the tongue to the floor of the third palate? I want to see under the tongue. Okay, looking under, that is the ventral surface of the tongue. I can see the frenulum. Looking at the ventral surface, you can see a blood capillaries passing through that. I continue still in the mouth. Now I want to access, I'll be accessing 3 cranial nerves. Here I can say 2. I'll be accessing 2. I want to access for the glossopharyngeal nerves, that is cranial nerves 9. I want to access that by using the gag reflex. And I can also like give something to the patient to test, which shows also that yes, this patient's cranial nerve 9 is working. Here I'm using the gag reflex. I will push this to the back of the mouth and the patient gag. So that shows that the cranial nerve 9 is working. So I will ask the patient to please, Mr. Amado, can you remove the tongue outside? Pass it in this way. Can you go this way, not outside? Can you go this way, up, down? Okay. During the assessment, I'm assessing for the cranial nerve 12. That is the hypoglossal nerve. So, and I have already assessed the cranial nerve 10. That is all the vagus nerves. How? My communication with the patient, the phonetics, the patient's tune of speaking. Since the patient is capable of talking to me, during that process, I'm assessing the cranial nerve 10. If the patient cannot talk, meaning there is problem with the cranial nerve 10, that is the vagus nerve. And I want to assess also the cranial nerve 5 together with the range of motion of the temporal mandibular joint, the TMJ, the temporal mandibular joint. Looking at the face, I can ask the patient to smile if I want to assess the facial nerves. Can you give me a smile? Okay, that shows that my patient's facial nerves, that is the cranial nerve 7, is working. The cranial nerve 5, that is the trigeminal nerve. I will assess this when the patient is able to move the mandible up and down, and there is movement of the mastitis muscle. Yes, on the jaw. So I palpate at the TMJ here. Open your mouth. Okay, there is movement. There is range of movement here, and you can see the muscle here are also movable. That shows that there is movement around the temporal mandibular joint, and the muscles, the muscles of the jaw also working, which shows that the trigeminal nerve, cranial nerve 5 is also sensitive. So, going further, I want to complete assessing everything on the head. Like I want to assess for the temporal artery, the position. Yeah, very palpable. So the temporal artery is very well pulsating, very palpable. And going down, I will be assessing now the neck and the 10 lymph node. Assessing the neck, I observe, I expect the neck go a little bit at the back. Assessing the neck, there's no swelling, I don't feel any swelling. I can see that the neck holds the head at the mid of the body, so which shows that there is centricity of the neck. I palpate the trochanter. Are you feeling any pain? I tell the patient to take a sip to see if the thyroid can move. Take a little sip. Take a little sip, like
Little drink.
Yeah, but please, let's be, I know I need to give you, but let's just assume the patient is taking a sip quickly. Can you just have sip? So you can see that there's a little movement here which shows that the thyroid is movable when the patient is taking in anything. So on the neck again, I have to assess for the jugular vein. Is there any distension there? No, it's not distended. Go coming to the other part, it's not distended. And I also palpate the carotid artery one at a time. Very palpable. Palpate this again. Very palpable. So they are they beat around 60 to 100 beats per minute. So to continue this assessment, I want to assess now for the 10 leaf node. I will first assess the first 5 on the head and go down to the last 5 leaf nodes on the neck and towards the clavicular bone. So I start at the back, come forward. I start at the back. I have the occipital here on both parts of the head. Occipital leaf node, just be straight. Okay, I come at the back of the auricle. We have the posterior auricular leaf node. At the front of the triangles, I feel the pre-auricular leaf node. I come to the submandibular leaf node and I assess for the submental leaf node. I go again to the neck. I start with the jungulo-digastric leaf node here. Go at the back of the neck. I assess the superficial cervical here. Coming anteriorly a little bit, I assess for the deep cervical chain. From the deep cervical chain, I come to the posterior cervical, and lastly for the leaf node, I assess for the supraclavicular leaf node at the mid-clavicular line above the clavicle. All leaf nodes are movable, there's no tenderness. Do you feel any tenderness? Do you feel any pain during the assessment of the leaf nodes? No. Fine, that's a very good one. So I continue to the thorax. On the thorax, I inspect. Please, as I told you, if you feel any discomfort, ensure you tell me. I will stop the assessment. I inspect the patient anterior thorax. Observe for any abnormal breathing, nothing like that. Is looking at the shape of the thorax, very symmetrical. Both parts of the chest is equal. I come laterally, I inspect, and come laterally again, inspect this other part. Come posteriorly, I look at the two sides of the posterior view. Okay, very symmetrical. I can't find anything different. So I compare the anterior posterior diameter to the transverse diameter. You can see that the anterior posterior diameter is twice the transverse diameter. Then I ask my patient, now I'll be assessing, I will be palpating the posterior thorax. Please, Mr. Amado, I want you to give me your back. So I'm really sorry, and I'll be taking for a little bit. Okay. So I palpate first for the entire thorax, thoracic region, posterior thoracic region. I'm palpating to see if there is any mass, is there any tenderness, but nothing like that. If you like to please ensure you tell me. To continue with this again, just after palpation, the general palpation, I have to palpate to see for the respiratory excursion or respiratory expansion. I want to see how the lungs can expand if it is expanding appreciably to determine that. Please, Mr. Osman, I want you to take this deep breath, very deep breath. Mr. Amado, go again. Okay, again. Okay, you can see that both pens move upwards and outwards appreciably, which shows that the expansion of the lungs is expanding equally, and there is equal expansion of the lungs during inhalation and exhalation. Then I want to palpate for the vocal parameters. The vocal parameters is to know whether this patient lungs vibrate during talking. So I'm palpating for this. I will tell the patient to repeatedly talk by either calling double numbers. So Mr. Amado, please be calling double numbers as I palpate through. Call double number like 99. 99. When you feel my hand, just be calling.
99.
You see? You can feel the vibration. Okay, so that is for the vocal parameters. Now I want to percuss my patient. Percussion comes in. I start at the apex of the lungs So you can feel that the sounds are well resonant, but as you come down, it becomes a little bit dull. So that is how it goes. So we want to also now, the last part of this is to orchestrate the thorax, the posterior thorax. So let me quickly orchestrate the posterior thorax to hear the lung sound. There are abnormal lung sounds which we'll be expecting, like crackles, stridors, and these are the type of lung sound we want to throw out. I start at the apex again. Be taking deep breath as I orchestrate. Be taking deep breath. So during this process, I will still tell the patient to take deep breath. Mr. Amado, be taking deep breath. Yeah, I want to orchestrate for the inferior lobe of the lungs, the inferior lobe of the lungs. Okay, there is normal lung sound here during the orchestration. All this procedure is a procedure I should, there are procedure I should repeat at the back as well, at the front, at the anterior aspect of the patient. But this for this tutorial, I will only repeat the orchestration at the anterior thorax. So on the anterior view of the patient, I start also with the apex. I orchestrate the apex of the lungs, which is always above the mid-clavicular line, above the clavicle here. If you want to orchestrate the trachea, you can also orchestrate the trachea, which you can find the sound here of the trachea. From there, you have the lungs, the upper lungs, which you can access the sound at the second intercostal space or in second intercostal muscle. Fourth intercostal muscle. Okay. So we come to the mid-axillary line for the inferior lobe. there is normal long sound. So continue with the thorax. We are going to also access and we are going to also access for the cardiac. So and this also on the thorax. So in accessing the cardiac, you first observe, you first inspect the precordium, that is the space where the cardiac occupies, which we all assume is on the left hand side of the sternum. Please sit and backward a little bit around here. So we are observing there. Is there any hips? Nothing like that. So we can palpate. Is there any abnormality you can find? Not like that. So you have to palpate the epicapos, which is the mid-clavicular line on the 6th intercostal space, intercostal muscle. You can feel it palpable, and this should beat around 60 to 100 beats per minute. And with access, we palpate again to locate the angle of Lewis. And locating the angle of Lewis, can you go leave at the back? Okay. We first try to locate the clavicular notch. The clavicular notch is here. Then we come down. You know, the sternum is divided into 3 portions. We come down a little bit. The first part of this is the mandibular. That is the border space of it. As you come through the mandibular, you can meet a first end here. There is a junction. So from this junction, this is what we call the sternal angle or the angle of Lewis. So all this now is the tail, and we have the sternum. So in accessing the cardiac also, we want to orchestrate. We have a sound. We have to orchestrate for a sound called the loop dub. That is, the loop is the S1 and the dub is the S2. And we have 5 sounds, as I said. The first sound is the aortic sound. The aortic sound is found on the left-hand side of the sternum at the second intercostal muscle. We orchestrate for it first. Adjacent to the second intercostal muscle, also on the right hand side, on the left hand side of the sternum now. This one was on the right hand side. Now on the left hand side of the sternum, where we can find the lungs, we are in the second intercostal muscle. We are palpating, we are orchestrating for the pulmonic sound. Just one intercostal muscle, one rib space. We are going to the third intercostal muscle. We are orchestrating for the Eaves point, where we get the Eaves sound. On the third intercostal, in the fourth or fifth intercostal muscle, we can access the tricuspid sound. And finally, we get the neutral sound, where we can get the epicapos at the mid-clavicular line at the 6th intercostal muscle. 10. Yes, you can hear it. Coming to the assessment of the abdomen, I will also let my patient go into a normal position, lying on the supine. Thank you very much. Okay, the patient pregnancy, we are still maintaining it. We have to ensure that throughout our procedure. So I pose, please, excuse me. I observe the abdomen, looking at the abdominal profile. Is it symmetrical? Looking at the umbilical, is that the center of the stomach? Yes, that's at the center. You see the movement of the abdomen in relation to respiration. That is also normal. Then after exposure, you look even at the color. Is the color of the abdomen the same as the entire body? Yes. So I start the abdomen by orchestration. Remember, our normal routine of assessment goes from inspection and go through palpation, percussion, and occultation comes last. But for the abdomen, it's not like that. We are starting with occultation and we are dividing the abdomen into 4 quadrants. We start with occultation. So we occultate the 4 quadrants, each for at least 5 minutes. But for this tutorial, we only taking it for a seconds. So we have occultated the abdomen for the normal vowel sound, and there was normal vowel sound. Why we do occultation before anything like palpation is because we don't want to alter the peristaltic movement of the intestine. So that is the reason we do that. So we also have to occultate for the arteries. We have the aortic artery. So we are doing vascular occultation. So during the vascular occultation, we are starting with the aortic artery, just below the sternum, above the navis. Then we occultate using the diaphragm of our stethoscope. We occultate. That is found around here. That is the aortic artery. From the aortic, we are coming to the renal artery, laterally by the side of the navi. Come here, and we go deeper around the iliac position. We are occultating for the iliac artery. And we come for the femoral artery, which we assume this place is exposed, which is on the femoral on both sides as well. There ends the occultation of the vessels. Then we are continuing with the abdomen still, and now we go towards palpation. We start to palpate. Percussion. We can pause first before going to palpate. We listen to the abdominal sound. Back there, you can see that we have the bladder there. That's the reason you can get a down sound. Around here, towards the liver, you can get a down sound. Around all the aspects, you are getting a timpani sound. That is a drum-like sound. After the percussion, we are going to palpate. We are going to palpate. In palpating, we are going to palpate the 4 quadrants again. So we start at the right lower quadrant. We go to the right upper quadrant, slight palpation. Left lower quadrant, we are palpating for any pain, any tenderness, any mass, any bulginess, and now we do the deep palpation. During the deep palpation, we want to know for rebound tenderness. How rebound tenderness? Do you feel pain when I'm taking my hand? Okay. So this is the palpation of the abdomen. So that is the end of the abdomen. So we now go to the musculoskeletal. Please, I want you to sit again. Let's be fast with this assessment. If you feel any discomfort, ensure you tell me. We are assessing the musculoskeletal. We are starting with the upper extremities. We first assess for the pulses. We inspect the muscles first. Inspection always comes first. The color of the upper extremity, are they the same? The muscle on both arms, is it the same? Looking at the hands, is it the same? Yes. we slightly palpate around the joint for any pain, any swelling, any tenderness. We observe it. We also palpate. Okay. Then I am going to assess for clubbing and the capillary a few times. I'm going to inspect the phalanges. Is there any clubbing? There is no clubbing. The phalanges are normal, and I try to palpate to assess for capillary refuse. I give slight pressure on the finger and release. Okay, and after releasing, you can see that there is uniform distribution of blood in less than 2 seconds. In less than 2 to 3 seconds, which means there is normal circulation. And I also have to assess for the elasticity of the skin. That is the skin turbo. Okay, the skin return to its normal after pinching up or pinching there. Please excuse me. Okay, so that shows that there is normal elasticity of the skin. And we want to also assess for the accessory nerve, the cranial nerve 11. Is it the okay? Yes, the accessory nerve. So I want you to just raise the soda a little bit up. Can it go up? Okay. Can you okay, bend the neck towards the face, let the face go towards the right. Okay, let the ear touch this without putting the soda up, and this other ear touch this as well without putting the soda up. Okay, without raising the soda up. Okay, let the chin touch the chest. Yes. Okay, so in this assessment, we have 11 is assessed. So that shows that the axillary nerve is working. So we want to now assess the range of motion and strength of the upper extremities. But before doing that, we have to palpate because we have an artery here which we have to palpate for. We have the brachial artery. Is it palpable? We come to the what? Radial artery, radial ulnar, and also palpate this, and that has to go on both sides. They are all palpable. So now, please, we are checking for range of motion. Can you raise your hand up in this direction? Down. This one again up. Down. Can you take it this way? Cross it over. Arm. Okay. At the back. Okay, back, okay. So that shows us there is range of motion here. Want to see the strength of on the arm. So we assess the strength of the arm. Can you try to flex the arm towards you? Okay. Can you try to flex it towards you? Okay, flex it, then I try to pull you. Stiff. Okay, it can go, so there is strength. Okay, it can go, so there is strength in the arm. So we are coming to the arm. Can you flex the arm a little bit? This way. Can it go straight? Up. Okay. The palm upwards. Okay. Fold the phalanges. Can this come? Okay. Open again. Okay. Open the phalanges. So move them. Okay. Then I want to see for strength. You try to push. When I try to push, you try to. Okay. Let me just try to fold the arm. Okay. This again. Try to fold. Okay. Pull on it. Fold it. Then let me try to pull. Okay. You keep on. Yeah. Okay. This cannot open. Cannot open. Let me see for this. Try to open the thumb. Okay. Okay. Try to close. Okay. That shows that there is strength in the arm. So we go further, go down, then we are coming to access the lower extremities. So coming to the lower extremities, we have to first start with extension. We expect both muscles of the leg towards the foot. Are they equal, the muscles? Are there any swelling at the joint? No. Are you feeling any pain when I palpate? The patella, is it movable? Yes. Patella bone is movable. That's a very good one. Then I palpate the pulses that are there. I start with the popliteal pulse at the back of the knee, very palpable. Come to palpate the posterior tibial pulse, well palpable. Palpate on both sides. Come here again, the posterior tibial pulse, palpate it. Then I want to see if there is range of motion of the foot and on the leg. Range of motion of the leg is what I'm coming to access. Can you put both legs together? Ensure the phalanges are pointed towards the ceiling. Take one leg up, straight, back. Take the other, okay, back. Now flex the knees. Let the knees go towards the chest. Okay, back. Flex this again. Let it go towards the chest. Okay, that's a very good one. Then I want to access the leg again from strength. Close the leg. Open. Okay, open widely. Try to close. Okay, so that is the strength in the leg. So I come to the foot. Let the phalanges face the ceiling towards me. Let the phalanges come towards me. Move the phalanges towards me. Okay, towards you again. Okay, let it go towards the middle of the center without moving this foot. Okay, that can happen as well. So want to feel for strength. Take it towards you. Try to push this by hand. Okay, take it towards you. Try to push my hand. Okay, there is strength. Towards me. Try to pull it towards you. Pull your foot. Okay. Towards you. Okay. So there is strength in the foot. So we want to access the heel opposite shine. We want to do the heel opposite shine movement. Take the heel and towards this foot and this shine here, up and down. Move it directly. I want to see for coordination. Down again. We are assessing for coordination and balance. Okay, the same thing. Repeat this one to this. Okay, down again. There is coordination and balance. Okay. Can you sit again to the bed? As I told you, I'll be changing your positions until I go to the end, until we end this whole process. So I'm coming to access for the rapid alternating movement. Put your hands on the leg, on the thigh, the palm facing the ceiling. Open it straight. No, the palm facing the ceiling. So close at the back. Open again. Close. Do this rapidly. Fast. Do this rapidly. Then close the eye. Continuously do it again. Okay. This one, there is coordination and there is balance. So I want to access for guilt. So I will tell my patient to walk around. So please, can you come down, walk around, let me observe the movement. It is a movement hazard. No, come again. I will be at the back of my patient to guide in case of any fall. So during that process. So now I will begin the run back test. The patient will stand stiff, stand with shoulders, okay, with all upper extremities towards you. Stand straight, yes. Okay, close the eyes. Okay, there is coordination and balance. So the patient, this is also checking for equilibrium. So we are now coming to check for equilibrium, for coordination, balance at the same time. So this now we are using the heel to toe movement. The heel to toe movement. Can you do that? Okay, can do that properly. There's coordination there as well. Come to the normal positions. Come to the normal position. I'm facing my patient. We are coming to do the nose to finger, finger to nose, and finger to nose to finger movement. You are going to remove your fingers at the center a little bit. So touch your nose. Again, touch your nose. Now close your eyes. Okay. Now touch the nose and touch my hands with eyes opened. With eyes opened. Now close the eyes. Okay, there is proper coordination. So far so good. I think here ends our tutorial, our head to toe assessment. So after here now, thank you very much. This ends your head to toe assessment. Thank you for complying. Before going out, because of the exam, I will ensure the patient's bed is well firm. And if there are rays, I will put up the rays. If there are 2 rays, I put up the 3 rays. If there are 2, I put up the 2 rays. And ensure the pallbearer is closer to my patient. So thank you very much, Mr. Amado, for complying.
Thank you too.
Hit that subscribe button to stay updated with more cool tutorials and let us know which topic you're down to explore.